All right, welcome everybody. We're going to go ahead and get started. Is there an echo or is that just only I'm hearing it? No, no echo? Okay. Welcome everybody to this year's Sampson Lecture. I'm excited that we've resumed in-person lectures this year. Dawn, you're the first person in 4 years to be here in person for this lectureship. I'd especially like to thank the family of John J. Sampson, some of whom are attending remotely. Welcome to you as well. Before I introduce our speaker, I wanted to just give a little bit of background about Dr. Sampson, for whom this lecture is named. John J. Sampson was born in 1898 in Galveston, Texas. He attended Berkeley, where he received a bachelor's and then a master's degree in 1922. He received his medical degree from Harvard in the early 1920s and completed his house officer training at Mass General, under Paul Dudley White. And I believe there's still a White service at, or at least there used to be anyway, at MGH. He spent most of his career as clinical professor of medicine here at UCSF and was a senior physician at Mount Zion. He's the past president of the California Academy of Medicine and served as president of the AHA twice, so 2 non-consecutive terms. Michelle and Don, I hope you're listening. First in 1938 and then again in 1960, so 20 some odd years later. He was very active in research and in clinical cardiology. Dr. Sampson passed in 1987, and this yearly lecture series is in his name. This year's lecturer is Don Lloyd-Jones. Dr. Lloyd-Jones graduated from Columbia College of Physicians and Surgeons and did his internal medicine and cardiology training at MGH, and then was a fellow at the Framingham Heart Institute, Framingham Heart Study, before moving to Northwestern in the early 2000s. He's currently chair of the Department of Preventive Medicine, the Eileen M. Folge Professor of Heart Research, and Professor of Preventative Medicine, Medicine, and Pediatrics at Northwestern University School of Medicine. His research interests include the study of the life course and mechanism of cardiovascular health and healthy aging, and the epidemiology of cardiovascular disease, risk estimation, and prevention. Most of you probably know Dr. Lloyd-Jones from his work in the guidelines, especially on prevention of cardiovascular disease. He's authored more than 800 peer-reviewed scientific papers, has been named a highly cited researcher each year for the past decade. Over the last 15 years, he's been a frequent leader of national clinical practice guidelines and policy statements for the AHA, ACC, and the NHLBI. He has received recognition as the AHA's National Chairman's Award in 2010, the National Physician of the Year Award in 2017, and Council on Epidemiology and Preventive and Prevention's Mentoring Award. And he has served as the AHA president from 21 to 22, the term just before Michelle, right? Yeah. So, again, I'm thrilled to have Dr. Lloyd-Jones here, and welcome, Don. Looking forward to your talk.
Thank you so much, Jeff. It's really an honor. I'm so grateful to be invited to give the prestigious Sampson lecture. It was really wonderful to learn a lot about Dr. Sampson's legacy and his service to the country. It sounds like in 2 world wars as a physician, and obviously kind of find those connections. Our mutual training at Mass General. He was a generation before me, admittedly, but also the connections with the American Heart Association. And, I think, as Michelle and I would both say, wouldn't wish that job on anybody twice. Once is enough. It's an incredible whirlwind of a year, but there's a lot going on. So real pleasure to be here and to really connect with lots of friends and meet new people, and especially some incredibly exciting young trainees and faculty members. So today I thought I'd talk a little bit about cardiovascular risk assessment. As you heard, something near and dear to my heart, something I've thought a lot about for the last couple of decades, and focus on current risk assessment models. We'll talk a little bit about what the current guidelines say, but there are brand new risk assessment equations, US-based, that I'll introduce to you or perhaps review for you, and then take a quick look forward at what might be coming in the future for risk assessment. So I have no relationships with industry. And I want to kind of first return to those first principles and remind ourselves why we actually assess risk. What's the point of assessing risk? Why don't we just treat everybody, or why don't we just screen everybody? And I think as physicians, we try to do things a little bit more focused on the individual patient rather than just a screen all or treat all approach. And so just wanted to remind us kind of why we think risk assessment is still a reasonable thing to be doing. We'll talk about the rationale of evidence base for that. And then talk about, as I mentioned, the current guideline recommendations, which really focus on middle-aged adults, currently ages 40 to 75. But then I want to introduce you to the new kid on the block. That's NKOTB for people of my generation who may remember what that means. But the prevent risk equations that were just recently published by the American Heart Association, I think are a nice step forward in this area. And then we'll talk about the sort of other age groups where we don't have quite as concrete recommendations about cardiovascular risk assessment in individuals over the age of 75 and in younger adults, where I think there's kind of the current frontier of how we're thinking about longer term and life course risk assessment. And then finishing up, as I mentioned, with look to the future about machine learning approaches. So I said this yesterday, but it's true of a lot of my papers. If you're ever having trouble getting to sleep some night, this is a really strong recommendation. Really pull this one out. You'll be asleep in just a couple minutes. But if you want to take a deeper dive on risk assessment and the tools that we currently use, perhaps this will be useful to you. And a more recent editorial that I wrote with one of my colleagues, John Wilkins, thinking about some of the issues I'm going to cover today. So again, if you're having a tough night, this will put you right to sleep, might provide some fleshing out of the ideas that I'm going to cover today. Okay, so why the heck do we bother doing cardiovascular risk assessment? Well, I think in many areas of medicine, we now have these risk scores and we plug them into clinical decision rule scenarios. And so they're useful often for diagnosis. We use risk scores to say, does this patient have enough of the signs and symptoms to say that they have this diagnosis or syndrome? We certainly use them for prognosis, especially in places like cardiovascular prevention. And again, they, I think, help in both those scenarios with treatment decisions. We know that signs and symptoms are rarely pathognomonic, quite rarely pathognomonic. And likewise, risk factors are not deterministic. Just because you have hypertension doesn't mean you are going to have a stroke. I suppose if we all lived to 200, eventually everybody would have a stroke. But other things happen. And just because you have a risk factor doesn't mean that you're going to play out all of the deterministic outcomes for that. So as physicians, I think we are trained, rightly or wrongly, but I think mostly rightly, to think in Bayesian frameworks. Am I worried about this patient? Do they seem like someone who's at high risk for a bad outcome, or someone who's extremely low risk for a bad outcome? Or are they in that broad middle? If they're really high risk, I'm going to do something likely more intensive, perhaps more invasive, to move to the next step. If they're really low risk, I'm probably not going to make that decision. And if in the broad middle, usually I need more information, right? To say, am I more worried or am I less worried about this patient who seems to be at intermediate risk for a bad outcome? So how do I determine whether I think this person is high, intermediate, or low risk? And this is where, again, risk scores and risk equations can be quite helpful. And then help me enrich the pool so that I'm making smarter decisions, both for the patient and for cost effectiveness reasons. So we do estimate risk. We use quantitative equations, both to understand mechanisms of disease, but again, perhaps identify some new risk factors or novel targets for therapy, and understand the relative contributions of these risk factors, because they're not all weighted equally, right? Diabetes, hypertension, cholesterol, lipid values, other things, smoking, they have different weights in terms of their overall risk for cardiovascular outcomes. So we want to understand how to relatively weight those things when our patients have these historical or physiologic factors. And the most important thing that I'm going to spend a couple minutes on is, without estimating risk, and absolute risk in particular, I can't compare the likelihood of benefit from a medical intervention to the potential harms of that intervention. It has to be done on an absolute risk plane. I can't use relative risks because they have different reference groups. So a tenfold excess risk, for benefit is not going to be compared to the same thing as a tenfold excess risk for harm. So I have to put these things on an absolute risk plane in order to understand the potential benefits and harms. So I'm going to play that out for you with a little bit more of a concrete example in just a moment. But the other thing I would say about this, particularly about absolute risk, is patients are terrible. There are a number of studies that have shown us patients are terrible at eyeballing their 10-year risk of having a heart attack or stroke. They tend to overweight some things, they tend to underweight other things, and they don't really, honestly, often have the numeracy to really understand, what a 10-year probability of heart attack or stroke might look like. So they tend to wildly overestimate risk. We all have these patients, the patients who's actually got a ton of risk, but thinks they're going to be fine and continues to eat, eggs every day. And those patients who are, let's call them the worried well, who think they're at super high risk, but are actually quite healthy. So they do a terrible job. Clinicians without aids, in fact, don't do a whole lot better. We do somewhat better, but we tend to focus on single values and lose the big picture context of the whole patient. So a number of studies have also shown us that clinicians need some help as well. And then the bottom line, again, is this comparing apples and apples, the absolute risk of benefit, the absolute risk of harm from anything that I want to do for this patient. So this is where these risk scores, I think, plug into clinical decision rules. If we think about, on this x-axis, the risk of whatever the event is, in this case, a clinical trial, we're thinking about statins, maybe it's the Jupiter trial, would tell us that above a certain threshold, treating that group of patients, I am likely to prevent a heart attack or stroke. Okay? Below that threshold, I'm just going to have to treat way too many people in order to make it a cost-effective decision. But that therapy, perhaps it's a statin medication, also comes with some risk of an adverse event. And I will throw out there a common, perhaps adverse event, which is new onset diabetes after being put on a statin. Now, I'm not going to go into this in detail, but if you think statins cause diabetes, please see me after. They don't. They may elevate blood sugar levels a little bit in some patients, but that patient was going to get diabetes anyway, and we don't prevent diabetes by withholding statin therapy, at least not usually. And so, nonetheless, let's call that an adverse event. And so we want to compare the zones where a patient might lie. Treating a patient down here at the very lower end here, I'm more likely to get an adverse outcome than I am to prevent a heart attack or stroke. Treating at the high end, I'm much more likely to prevent a heart attack or stroke than I am to cause a new case of diabetes. And then there's always going to be this gray zone, right, where I might want to enrich my understanding of where this patient truly lies on the risk spectrum. So that's why it's really helpful, I think, to line these things up on a common plane of absolute risk and absolute benefit. Okay, and we do have some data about absolute benefit from, on the left, the cholesterol treatment trialists, on the right, the blood pressure treatment trialists. And they've shown us that the risk of the patient is a major determinant of the efficiency of our therapy. So just looking at the left side here, what you see is for any given level of LDL cholesterol lowering with statin therapy, the function of the patient's baseline risk shown on this axis tells you how many events you will prevent if you treat 1,000 patients. So you can see the higher the baseline risk of the patient, the more events you will prevent. Now, this makes sense intuitively, right? High risk, greater reward for a given relative risk reduction from therapy. But the same thing is true for blood pressure lowering therapy as well. Now, as I mentioned, there are also potential adverse effects from medications, and focusing in on statins. This is a figure from the 2013 cholesterol guidelines where we set the treatment benefit threshold at 7.5% based on clinical trial results. And so if you haven't really thought, where did 7.5% come from? This is exactly where it came from. This is our thinking process visualized for you here. On the left, the red line represents the number needed to harm to cause a new case of diabetes. So with a moderate intensity statin, I would have to treat 100 patients to cause one new case of diabetes. The curvilinear line is actually the risk of the patient and the number needed to treat to prevent one major cardiovascular event in 10 years, okay? So where these two lines intersect is sort of the line of unity. At that point, I am as likely to prevent a heart attack or stroke as I am to cause a new case of diabetes. So any risk level really above about 3% means that I'm starting to be much more likely to prevent a heart attack or stroke than I am to cause diabetes. The calculus is a little bit different on the right, where we're using a high intensity statin, higher dose. And you can see where the lines intersect there is between 5 and 7.5% 10-year risk. This is where the 7.5% threshold comes from to determine statin eligibility. Because again, above there, we are more likely to be preventing heart attacks and strokes than potentially causing an adverse event, even if you think those things are equal. So this is why, again, having absolute risk estimates is really helpful. So with all that context and background, let's talk about the current guideline approach to primary prevention of cardiovascular disease in 40 to 75-year-old patients. And you're probably familiar with this algorithm. This is from the 2017 blood pressure guidelines. And prominently, if the blood pressure is high enough, everybody gets treated right away. So stage 2 hypertension on the far right, if the blood pressure is above 140/90, everybody gets medications on day one once the diagnosis is made. If you're below 130/80, lifestyle for everybody. And then this newer group of stage 1 hypertension, if the systolic blood pressure is between 130 and 139, or the diastolic between 80 and 89, yes, the blood pressure is elevated, but the context is really important here. We're not going to jump right to medications unless the global risk, considering the presence of diabetes, the presence of smoking, the lipid levels, the age of the patient, we're not going to jump to medications right away unless that 10-year risk estimate is also over 10%. Again, for cost effectiveness and efficiency reasons, we've got a little bit of time here to see if lifestyle will lower the blood pressure alone without committing the patient to medical therapy. So this is exactly the rationale that's used in the blood pressure guidelines, and the same exact thing is used in the statin guidelines as well. We do a 10-year risk estimate, put the patient into the buckets of low, borderline, intermediate, or high risk, and the higher the risk, the more quickly and the more intensively we're going to treat the cholesterol with statin medications. Okay, but as we mentioned, there are those patients in the large middle gray zone, right? So it's easy if they're up here to high risk. If their 10-year risk estimate is greater than 20%, that is more than equivalent to secondary prevention. So routine recommendation for immediate statin therapy or other therapies to lower the LDL cholesterol if needed. At low risk, again, unlikely that we're actually going to see some benefit. We would have to treat a lot of patients down here to see benefit. So we're going to focus on lifestyle. But in these two intermediate groups, we want to think a little bit, right? Are we missing someone who truly actually is at higher risk than we appreciate? Or is someone who's got optimal risk factor levels perhaps only getting a higher 10-year risk estimate because they're older, right? That's not wrong, but it might not need intervention quite as much. And so, we might want to reclassify these individuals in the intermediate zones to understand if they're truly actually more high risk or low risk. So the way we do that first is to take the population level risk estimate from step 1, and we actually try to bring it home to the patient sitting in front of us today. Personalize that risk estimate by understanding, are there other features, what we call risk enhancing factors, that might color our determination about their risk? Family history, presence of HIV or chronic inflammatory disease, chronic kidney disease, or other things. I think those are very helpful in individualizing the risk estimate. And then finally, if we're still uncertain, let's actually go answer the question we really have. Does the patient have disease? And if they do, much, much more likely to want to be intensive in our approach to that. So we calculate, we personalize, we reclassify. If you're still awake, that's CPR, but it's not that kind of CPR. Sorry, Jeff. It's the other kind of CPR, which might prevent your kind of CPR. How do we do this? Well, we calculate the absolute 10-year risk using the pooled cohort equations. They've been around for about 12 years now, and they give us this absolute risk estimate. When we updated the guidelines in 2018-19, there had been a lot of research done on the pooled cohort equations. So we were able to deploy them, I think, in a smarter way than just saying, use these and they will help you make your decision. And that's where these extra layers of this sort of personalization and reclassification were then deployed, I think, to help us make smarter decisions. Lots of literature, which I've consumed avidly, having been part of those 2013 risk guidelines, to say, how do the pooled cohort equations actually perform in real world clinical populations? And I think what we've seen pretty routinely is at the decision threshold of 7.5%, they actually tend to work quite well. They're well calibrated. They tend to discriminate quite well. So in broad clinical populations, at your decision threshold, they tend to be quite reliable. They do overestimate risk, but it tends to be when the 10-year risk estimate is 15% or higher. So yes, they do overestimate risk, but in a zone where you might not really care so much because that's a patient you're much more likely to treat already. And so if you're overestimating risk a little bit, it's not going to change your decision. We do see, however, in a number of cohort studies and clinical studies, that if you're looking at a patient population that has higher socioeconomic status or has been heavily engaged in preventive therapies already, you are going to overestimate risk with the pooled cohort equations. And this is true of pretty much any risk equation, but certainly true here. So be aware that if you're looking at a patient who looks more like this demographic, that in fact, you're probably overestimating their 10-year risk. And likewise, at the other extreme, if the patient has lower socioeconomic status, has chronic inflammatory conditions, you're almost certainly underestimating their 10-year risk when you're looking at the pooled cohort equations. So always, I think, you have to put these things in context. It's not a perfect number and never was intended to be. You have to then, I think, contextualize it. And these data, I think, really help us do that. And that's where this clinician-patient discussion comes in to try to bring it home to the individual characteristics of the patient. So if you haven't already played with the pooled cohort equation estimator, here are some of the ways you can find that. Just Googling pooled cohort equations, you'll find the online version or the app. This is what it looks like online. You plug in the age, sex, race, systolic blood pressure, total cholesterol, HDL cholesterol, history of diabetes and smoking, and whether they're on hypertensive treatment. That's the sort of minimum needed to get a risk estimate. The other things are sort of gravy, if you will, but they can help you with dynamic and recurrent risk estimation as well. So when you plug that in, you get your 10-year and also get a lifetime risk estimate that can help you with your discussions with the patient. But this next step, I think, is really important because, again, the 10-year risk estimate comes to us from population-based studies. So the patient wants to know, is it going to rain tomorrow? Should I bring an umbrella? Am I going to have a heart attack or stroke? Should I take a statin? Our best ability to answer that question is you have a 15% chance in the next 10 years. There's a 15% chance that it's going to rain tomorrow. And so the personal reaction to that information is kind of quite important, right? Some people would say, I don't need an umbrella for a 15% chance. Or a lot of people might say, given that the consequences of a heart attack or stroke are severe and potentially fatal, maybe I do want an umbrella. So it's really important to walk the patient through what this information means. And again, especially to put it in their individual context. There are things in the risk equations, there are things not in the risk equations that are quite important for their health outcomes. And you see here the list of things that in general, if present, we would say would up risk that patient. So if they have a history of in women, reproductive associated problems like gestational diabetes, like a hypertensive disorder pregnancy, you should consider them at higher risk than you might otherwise have thought. We talked about chronic kidney disease, chronic inflammatory conditions, other things that again might cause you to underestimate risk and should push you higher. So contextualizing it, I think, is important. And then again, if you remain on the fence, and I have patients like this where, again, they might be 72, avid tennis player every day, really thin, incredibly good diet, you know, and I'm getting a 13% 10-year risk estimate for them, even though their cholesterol levels are really good and their blood pressure is pretty good. So do I treat that patient just based on that number? No. You know, I'd like to know a little bit more. And in those situations, I've often gotten a coronary calcium score of 0, and I've felt great about not necessarily committing them to statin therapy because their risk in the next 10 years is substantially lower than what I thought it was, because they don't have atherosclerosis, or at least not mature atherosclerosis. And I've had other patients who have, you know, coronary calcium scores of 500, and we quickly change our approach and, you know, certainly get them on maximal preventive therapy. So this can really be sort of a nice final discriminator on top of what you've done with them up to this point as well. Okay, so we also made recommendations about the level of coronary calcium that might prompt you to make a different decision. We talked about a coronary calcium score of 0 actually being quite effective at reclassifying people, provided their 10-year risk estimate is below 20%. If their 10-year risk estimate is above 20%, you're not really reclassifying them to a much lower level where you should avoid a statin. So we don't even really bother. If the 10-year risk is over 20%, they're likely to have high calcium. And even if it is 0, you're not going to reclassify them substantially enough. And likewise, if the coronary calcium score is over 100, you're going to upclassify people, even if their 10-year risk estimate is in the roughly 10% range. So that might make you kind of make a different decision for sure. Okay, the other thing I'll say about this, and this again gets to medications that might have both risks and benefits. Aspirin therapy for primary prevention of cardiovascular disease. Part of the guidelines until 2018, when 3 separate trials came out and told us, wait a minute, in the current environment, aspirin is actually not providing as much benefit as we thought it used to, and yet the bleeding risk is still there. And so guidelines pulled way back on recommendations for aspirin for primary prevention therapy, very appropriately. But since then, as happens, people nibble with evidence. And these are data from the MESA study, Miguel Canzo-Sacharica, who showed us that, in fact, if the coronary calcium score is over 100, and again, what you're seeing here with the red lines is the number needed to harm, that is to cause a major bleed with aspirin therapy, compared to the number needed to treat to prevent a heart attack or stroke. What he found was that if the coronary calcium score is over 100, then you are, again, more likely to be preventing a heart attack or stroke in this patient with advanced atherosclerosis than you are to be causing a major bleed. So that might be a nice, again, decision threshold that if you find a higher coronary calcium score, maybe that's the enriched pool of patients where you should still consider aspirin therapy and not just routinely withhold it in everybody in the primary prevention scenario. So again, I think a nice demonstration of how you can use this across multiple different preventive therapies. Okay, so CPR, you've got it. And we do try to do this CPR now, so we don't have to do that CPR later. Okay, so let's get to that NKOTB, the new prevent risk equations for adults. Now notice 30 to 79 years old. So these new equations actually extend our ability to predict risk for both 10 and 30-year windows down to 30 years of age, which was certainly one of the, I guess, problems, but certainly limitations of the pooled cohort equations was they only started at age 40. And that's kind of frustrating because we know that people are accruing risk during their 30s. So I think that's a nice step forward for these. If you've been monitoring this, there have been a series of presidential advisories and scientific statements led by our current and immediate past president to focus in and think about a new paradigm of cardiovascular disease prevention, focused not only on the vasculature, but also our major public health problems of obesity and the metabolic disarray caused by obesity, as well as chronic kidney disease. And all of these things, and this is nicely outlined in these 2 statements, all these things really have a complex interplay and they feed each other in terms of elevating cardiovascular disease risk in the near and long term. The other thing that I think makes a ton of sense into why we would want to bundle cardiovascular, kidney, and metabolic disorders is we now have therapies that cross these disciplines, medications that were designed to be hypoglycemic medications for diabetic patients that actually cause weight loss and improve metabolic parameters that also actually at the same time reduce cardiovascular disease event rates, right? So SGLT2 inhibitors, GLP-1 receptor analogs. We have medications for chronic kidney disease. I'm thinking of finerenone, which again, not only prevent progression of chronic kidney disease, but also improve metabolic parameters and prevent cardiovascular disease events at the same time. So because we now have tools that have sort of multiple heads and it can attack all these things, and because the common underlying sort of pathophysiology of these conditions does trace back early in life to underlying metabolic problems, it makes sense to lump these things together and start to think about the patient much more holistically, rather than just thinking about their kidneys, or just thinking about their weight, or just thinking about their cardiovascular disease. So that's the sort of underlying rationale for our new cardio-kidney metabolic syndrome. A staging kind of akin to what you've seen in the heart failure guidelines. So stage 0, optimal cardiovascular health. Stage 1 represents either excess or dysfunctional adiposity. Stage 2, metabolic risk factors present or chronic kidney disease. So this is now also has hypertension or dyslipidemia or diabetes. Stage 3, subclinical disease, so demonstration of either left ventricular changes or coronary calcium, or just having a high enough predicted 10-year risk that it puts you in this sort of secondary prevention-like mode. And then stage 4, the presence of clinical cardiovascular disease. And so this is what it looks like. And I think what's nice about this is, again, it helps us think about the whole patient as one thing and not just separate organ systems. And also that up until you get to stage 4, where clinical cardiovascular disease is present, patients can regress. They can move back upstream if we're doing a good job treating and controlling risk factors, if we're helping them with their weight journey and doing a number of other things. So I think it's a nice framework. Would recommend it to you for review. I don't think this one will put you to sleep quite as much as my work does, but hopefully not anyway. So as part of this effort, AHA asked us to develop new risk equations, just understanding some of the limitations of the pool cohort equations and wanting to incorporate some of the newer evidence about the importance of kidney measures in preventing and predicting cardiovascular risk. And so that's the genesis of these new PREVENT equations, as they're called. And they fit into this framework right here under assessing cardio-kidney metabolic risk. We'll come back to that in a second. But here's what the website looks like. And AHA is working on plugins for Epic so that you can have a dot phrase to calculate the PREVENT 10-year and 30-year risks. But if you want to play with it in the meantime, the URL is on the bottom there, or you can just Google PREVENT equations and it's the first thing that comes up. So this is what it looks like again on the sort of web framework. I think importantly, major step forward methodologically in developing these equations is that instead of about 30,000 individuals with a few thousand events, these were developed in more than 3 million individuals, combining both population-based studies and large electronic health record repositories. So this is very contemporary. These are current patients essentially, and it's very real world. It's not just the sort of rarefied air of a cohort study, you know, like Framingham or some of the other cohort studies. It's real patients in real time and their real outcomes, which I think is a huge strength. So more than 3 million people in the derivation setting, more than 3 million people, separate people from different locations in the validation study. And I think another strength that we didn't just divide it in half and sort of, you know, prove that randomization works. We actually used different people for validation than we did for derivation. These are still sex-specific models, so they're different models for men and women. There are 10 and 30-year risk estimate outcomes. They adjust for competing risk. Don't worry about that part. But notice what I didn't say. Unlike the pool cohort equations, we do not have race-specific equations anymore. A lot of good reasons for that. This is not to say that disparities don't exist by race anymore. We know there are huge disparities in cardiovascular disease associated with race, but they're not caused by race, right? Race is a social construct that represents, and Michelle should be giving this part of the lecture, not me, but represents so much more about social and structural differences, especially in this country, that are race associated, and the lived experience that gets internalized in this country that does increase cardiovascular risk. So we were able to, at least as a beginning point, replace race with a social deprivation index that, at least for the moment, seems to be performing in a reasonable way to represent the risk that used to be associated with race. Importantly, and I think this is a huge step forward and reflects, again, our change in therapies that can prevent multiple different types of cardiovascular outcomes, the outcome you will get routinely is total cardiovascular disease, which includes both atherosclerotic events and heart failure. So that's a huge upgrade, I think, from the pool-cord equations. You could also still get each of those individually as well. So kind of a nice feature of this framework. So this is the sort of the core model, if you will. Those traditional risk factors, age and sex, still incredibly important at predicting event rates. And then if you have them, you can also plug in the patient's zip code to get the social deprivation index that adds value to the model. And if clinically indicated and you have it, you can plug in the hemoglobin A1C for pre-diabetic and diabetic patients, and you could plug in the urinary albumin creatinine ratio for hypertensive patients or patients with chronic kidney disease. And all of these things add value to the model. You are not required to have them to get an answer from the model, but if you have them, you'll get an even better answer. So we built it that way so that it could be useful for all situations. So I think I've kind of reviewed what the upgrades are, if you will, with the new prevent equations, but happy to answer questions about them. I didn't highlight this too much, but you do get the 10-year risk estimate, but you also get a 30-year risk estimate. And sometimes that can help with your communication with the patient. We're not just thinking about the next 10 years, we're thinking about essentially a good chunk of your remaining lifespan. And those 30-year risk estimates, pretty much guaranteed, will be a lot higher than the 10-year risk estimates. Okay, so won't go into detail on this, but just to say, these people in the derivation and validation samples look like our patients. This is a very broad swath of the American population. I would say fairly representative, a little underrepresentative in terms of Hispanic adults. So we're working on getting more cohorts where we can make that more robust. But in general, pretty darn representative, which is a good news. In general, by the metrics that we usually evaluate these models on, discrimination, calibration, they're doing a really nice job. And we don't see the problems of overestimation that we saw with the pool-cord equations, very importantly. So I think that's a huge step forward as well. And maybe even more importantly, by replacing, if you will, race-specific equations with a generalized equation that has the social deprivation index, other than for Asian adults in predicting heart failure, where we under-predict a little bit, other than that, we actually see that the calibration is right on par with where it should be. So if we predict an event rate of 10%, the observed event rate in the validation cohort was 10%. So we're kind of right on with our calibrations, regardless of the race ethnic groups, which is good. In the paper, you'll see this kind of gives you a framework to understand what does it take to get to certain different levels of risk. So we have those heat maps, but I won't go into that in too much detail. But just to kind of wrap up this part and remind you, why we think these are major steps forward. One, we can't ignore heart failure risk. It's a huge and growing problem in terms of public health burden. I think it was desirable to remove race from the pool-cord equations and get to a better place with this, as long as we could represent and replace it so that we're not ignoring the race-associated disparities, but we're actually ascribing them to the things that actually are seeming to be making the difference. Kidney function, again, part of this whole framework. And then if you have the data on zip code or HbA1c or UACR, those will enhance the predictive ability of the equation. Okay, so that's kind of it for middle-aged group. And moving on now to our older adults, the current sort of reigning guidelines suggest, I guess in a word, individualization. This is probably the best way to put this. If you have somebody who's 75 years of older, a very weak 2B recommendation that you might consider it. So, okay, you might consider it. But, I think you need to think about, what do you have a sense of their expected longevity? Are they going to live long enough to actually see the benefits of a statin? Or are we just creating polypharmacy that's not ever likely to benefit them? I think that's a really important discussion to have with yourself and with your patient. If they're doing well and they're older than 75 and they're already on a statin, reasonable to continue that or to withdraw it if, again, there are other more compelling and problematic chronic diseases that they're dealing with. So again, soft recommendation, but worth thinking about. And then finally, if you've got somebody who's quite robust, they're 76 to 80, and you want to go find a coronary calcium score of 0 so that you can avoid treatment, reasonable thing to do, and relatively low cost, but usually, unfortunately, not covered by insurance. So guidelines are pretty soft on these recommendations. But again, I think the key is know your patient and individualize to their situation so that you can make the best decision for them. Okay. So here's where I think the current frontier really resides, which is individuals less than 40. Under the pooled cohort equations, as you know, we don't have a way to estimate 10-year risk. We can estimate lifetime risk. But I think there's been some frustration with that, and it's well placed. We'd like to do a better job for our patients. So I think there are now some options to consider. As I mentioned, the prevent risk equations do cover patients down to age 30. So that's helpful. We do have lifetime risk estimates available already for patients ages 20 to 59. That might help inform your thinking about the patient. And, I will say in my practice, I use those for trying to motivate more and better adherence to lifestyle interventions. I don't tend to use them for treatment decisions because I'm not sure that's what they're really designed for, but I think they're quite useful in showing someone their lifetime risk estimate and saying, now's the time where we should really work on these lifestyle factors. You can use cardiovascular health scoring. I talked about that in my talk yesterday for medical grand rounds. And those are beneficial and useful at any age. We're going to spend a moment on polygenic risk scores, kind of a new kid on the block also, which I think are interesting. And then don't forget, we know what causes atherosclerosis, and the central molecule is ApoB containing particles. Never forget that, please. So if you have a patient who has very high cholesterol, and I'm not saying, not even waiting till they get to over 190 LDL cholesterol, if they have, even above 140 or 150, knowing what their particle number is really important. And whether that's also associated with lipoprotein(a). This is not guideline yet, but boy, I think it's really important. If you have a person in their 20s who is in the top decile of ApoB, has a high Lp(a), all those sorts of things, I would start to be thinking about being pretty aggressive, because now's the time you can actually arrest plaques before they get to a point where they're going to progress regardless of what you do. So we get pretty intensive, at least with our diagnostic strategy, in younger patients who have high LDL or non-HDL cholesterol, just so we know exactly what's going on in there and how soon we might want to get a little bit more aggressive with them. Okay. So lifetime risk estimates, as I pointed out, are currently available. So if you use the current pooled cohort equation estimator, enter those risk factor values, you'll get a lifetime risk estimate as well. And that can be useful for communication. Remember that the vast majority of adults in this country, especially if they're younger than age 50, have a 10-year risk estimate that is less than 7.5% and a lifetime risk estimate that is more than 30%. So you get a very different picture of somebody if you think about both of those 10-year and lifetime risk estimates. So across all adults, as you can see, the majority have a low 10-year and a high lifetime risk estimate. What about cardiovascular health scoring? I spent a lot of time on this yesterday. Please don't feel like you have to go back and look at that. But AHA offers a way to measure someone's cardiovascular health today that can help them focus on improving, especially lifestyle factors that can help their long-term outcomes, increase their longevity, as well as increasing their health span. But we know that even at young ages, this can work really well. So these are data from one of our faculty, Mandy Mohammed Parak, who classified young adults, ages 18 to 30, into high, moderate, or low cardiovascular health status. And notice that in the blue, people with high cardiovascular health, even as early as age 18, had very, very low event rates for premature cardiovascular disease over the next 30 years in the Cardia study. So knowing cardiovascular health, working on it even early in life can be quite powerful at preventing even premature event rates, and certainly even longer term ones as well. Okay, so we're going to spend a couple minutes on polygenic risk scoring before wrapping up. I think there's a lot of excitement about polygenic risk scores, and rightfully so. This paper, I think, really kind of moved the field forward using data from the UK Biobank. These investigators created polygenic risk scores using whole genome sequencing in the 500,000 individuals of the UK Biobank for multiple different chronic diseases of aging. And as they pointed out, prior to this, we had some initial polygenic risk scores with 50 different variants across the entire genome. And then it got a little bit better with 50,000 variants. But they used actually 6.6 million SNPs, 6.6 million different variants associated with cardiovascular risk to create in each individual patient a risk score. So your risk could vary from minus 6.6 million to plus 6.6 million if you got all the bad stuff, minus 6.6 million if you got all the good stuff. And that really helps spread people out in terms of their propensity, their genetic propensity for cardiovascular events. And as you can see, particularly at the higher end of risk, they were able to discriminate more and more people who might be worthy of intervention. So this, I think, provided a lot of promise. There is some work to be done. It works well in people of North European ancestry. It does not work particularly well in people with other heritages. So beware. Newer polygenic risk scores are coming, but that is definitely a limitation of this one. And when it's been brought into different cohorts, its performance as a risk prediction tool varies widely, but especially based on age. So in its home cohort of the UK Biobank, you can see there was a modest improvement over and above traditional risk factors when you use the polygenic risk score. But in US-based cohorts like MESA and ERIC, which are community-based cohorts, in fact, there was no improvement in the usual metrics we would use to say whether the addition of a new biomarker, in this case, the polygenic risk score, actually improved our ability to predict risk. So no improvement at all in people, in this case, with a mean age of 55 to 65. So at that point, their own risk factors were more important than what their genetic predisposition had been, right? Kind of makes sense, right? They had sort of lived through their genetic predisposition window, and their cumulative exposure to blood pressure, cholesterol, blood sugar, smoking was far more important than what their genes had been at birth at that point. So not so useful perhaps for middle-aged and older individuals, but in our Cardia cohort of 18 to 30-year-old adults, we did see that people in the top 20% of this UK Biobank polygenic risk score were at substantially higher risk, shown in the yellow, in these young adults age 18 to 30, compared to folks in the lower 80% of the polygenic risk score. So I think this might be the window of opportunity, is in young people in particular. Polygenic risk scores may help guide us in the future when we learn how to deploy them. Not recommending that you get whole genome sequencing on all your 20-year-olds. Please don't misunderstand me. But I think, again, we're starting to perhaps build a case that this might be useful. Cost effectiveness might be another question to be answered. And then I showed some of these data yesterday, but polygenic risk scores, I think, might be particularly useful in young people, because if you balance the predisposition of risk, the propensity related to genetics, against whether lifestyle can trump that, these data, I think, are quite telling. So we're just going to focus on the top and bottom here. The horizontal bar represents the lifespan of that group. The black part of the horizontal bar represents their health span. How long do they live without cardiovascular disease? Looking at the extremes up here, we have somebody with really good genes. They have a low polygenic risk score, but they have bad lifestyle. And at the other extreme down here, we have people with really bad genes, but good lifestyle. And notice what lifestyle can do for you. Compared to these folks with great genes, but bad lifestyle, the folks with bad genes but good lifestyle, on average, lived 12 years longer. On average, lived 12 years longer, 19 years longer without cardiovascular disease, and 7 years longer on average after a cardiovascular event. That's pretty amazing, right? I mean, I think what this says to me is not that polygenic risk scores are bad. What this says to me is if we could identify people with bad genes early in life and really enforce in them the need to pursue healthy lifestyle, wow, they can really change their outcome, right? And so I think that's maybe another niche use for polygenic risk scores. Okay, so I think you've got that. Last minute, I think this is in evolution. Machine learning scores are really, I think, of great interest. Can they outperform our statistical, traditional statistical models? I think the answer is undoubtedly yes, but we haven't figured out how yet. Mathematically, they will perform better, no question about it. But they require different inputs. So here's one example from the MESA study where they used machine learning and they plugged in pretty much everything that had ever been measured in those participants. And guess what? They did a little bit better in terms of risk prediction. Now, as a clinician, I sort of shudder to think that I would have to order all these tests to get what is a real but modest improvement in risk prediction. That's probably not going to happen. Even if we had the money to do it, I just probably couldn't handle all that data. Again, I think, a lot of data is needed to train these models. We need to do some reduction of complexity to make sure we're doing things that are clinically reasonable. I'll just skip forward to this one. Here's a meta-analysis, which I'm glad they did, but the problems here were they found 55 studies that have done risk prediction for cardiovascular disease using machine learning models. But it's really hard to meta-analyze things when every single one is different from all the other ones. So different outcomes, very different methods, all sorts of different machine learning model approaches. And again, very diverse inputs, right? They all had different amounts of data that they were training their models on. Long story short, even given those limitations, these C statistics are way better than we would get with a traditional model. I think we just need to kind of work out some of the logistics and the sort of practical issues. So undoubtedly, machine learning models ultimately will be better at risk prediction. But I think these are some of the questions that we still have to answer about them. And we need to make sure, especially, that they are practical and don't overburden either the patient or the clinician in order to make them useful. Okay, I would be remiss if I didn't acknowledge the kind of fun and very interesting work that Peter Gins is doing with his proteomics scores. I know I'm bringing coals to Newcastle, but this is really cool stuff. And I think it does represent sort of, rather than upstream things, these proteins are probably very much in the causal pathways and in the risk-creating pathways for events. And so I think there's some really nice work being done here and some promise for these kinds of approaches as well. Again, as long as they're feasible and cost-effective to do so. Okay, so that's pretty much it. I want to make sure we have time for questions, so I'm going to stop here. But here's where I think we're going for young children and early adults. I think we should start to think about propensity, right? That family history, and especially maybe ultimately as represented with a polygenic risk score, can we identify those people who especially need to launch into healthier lifestyle trajectories early in life? From ages 20 to 39, those determinants, that central molecule that causes atherosclerosis, don't forget about those ApoB particles. If your patient is in the top, say, decile of the distribution for that age group, they're on the fast track for events. So we want to get as aggressive as possible, I think. Guidelines cover middle age, I think, pretty well at present, and we'll see how they evolve in the next couple of years. And then don't underestimate the value of knowing whether the patient has disease, not just risk for disease, but actual underlying disease. And that's where I think things like coronary calcium imaging can be quite useful to help you make smarter decisions. And that's it. Thank you so much. So grateful to be here and to be with all of you.
So we have time for a few questions. Jamie, you can maybe just let us know if there are questions online, but we'll start with Bill.
Thank you. Mhm. Yeah. 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 Well, in part you do, right? If you have a patient who has hypertension and dyslipidemia,